a diabetes patient, or what is the relation with transplant and diabetes? Again, we may have pre-existing diabetes prior to transplant. People can develop post-transplant new-onset diabetes, which may be permanent, or what is very common almost in almost everyone is transient post-operative hyperglycemia. We need to know what is the influence of the NODAT, new-onset diabetes, on outcome and risk factors and management. So if we see the timelines with regards to transplant, some people are pre-diabetes, but not all are evaluated. About 65 to 90% without diabetes will develop some inpatient hyperglycemia because of steroids and immunosuppressants. But overall, within the first year, about 15 to 40% of solid organ transplant will develop diabetes, and then subsequently about 5%. So there has been some change in the terminology with regards to new onset diabetes of after transplant, which excluded pre-transplant diabetes as well as transient hyperglycemia. But that may not be always feasible, something like GDM. And so it is new. The post-transplant diabetes is a new terminology, which is basically newly diagnosed diabetes post-transplant, irrespective of time of onset. It's the time of diagnosis which is mandatory. Again, the transient hyperglycemia is excluded. If you look at the ADA definition, again one needs to make a formal diagnosis when the patient is on maintenance immunosuppressant and without infection. OGTT, oral glucose tolerance test, is preferred. Again, another very important point, you do not need to modify immunosuppressives, because immunosuppressives are associated with transplant rejection and death. So you give the best immunosuppressives irrespective of their diabetes risk. Again, if you look at the recent guidelines, avoid making the diagnosis within the first 6 weeks. Mainly OGTT, but fasting and A1C can suffice as well. Initial indicators, if you monitor, there's a rise in afternoon glucose because of the steroid as well. And even in non-diabetes who do not develop diabetes, need to monitor regularly as well as prior to transplant. Limitations, OGTT is poorly reproducible. A1C anemia is a factor. The A1C cutoff is lower. And initial period is mainly the postprandial hike rather than fasting. So that's the limitation of fasting. So compared to type 2 diabetes, post-transplant diabetes, diagnostic difficulties which I just mentioned, again they have some multiple, especially drug-related pathophysiology as well as uremia. Again, the complications occur much quickly and much earlier, whether it is cardiovascular disease, infection, graft failure, as well as higher mortality. So lower graft survival, patient survival, as well as increased cardiovascular disease. So we had seen increased risk of hospitalization, reduced patient and graft survival, as well as hospital admissions because of infection, mainly urinary infection and chest infection. First 1 year, the cardiovascular complications are much less. And it is in new onset diabetes, the risk of adverse events, including hospitalization, as well as worsening of GFR, especially, is as bad as in a type 2 diabetes diagnosed. So those who develop new onset diabetes, it is not innocuous. 20 to 40% can develop, and in them the outcomes are similar almost to a pre-existing diabetes, whether it is infection, whether it is worsening of GFR after transplant, or graft dysfunction or hospitalization. That is something we must recognize. Again, within the first 45 days, we shouldn't diagnose. Then we should be only treating with insulin. The targets are similar in hospital, 140, 180. Beyond the 45 days OGTT, the standard fasting PP and glucose A1C cutoffs. And again, one should also monitor every year. The lifestyle modification always has to be initiated. The oral anti-diabetic agents, again metformin, only the GFR more than 30. DPP4 inhibitor, this is what is the Indian point of care guidelines which we had published, that the DPP4 second line or even first line, if metformin is not permissible. Again, one can use the secretagogues like sulfonylurea or glinides, but risk of hypoglycemia is important. Again, the data on SGLT2 inhibitor is not that strong. There is increased risk of urinary infection as well as decreased renal function. their efficacy, glycemic efficacy is lower. GFR is something we need to monitor as well. The GLP-1s, again, increased gastrointestinal intolerance has been reported, but efficacy remains same. Again, we need to try to taper the prednisolone dose to 5 milligram. Also tacrolimus at the minimal possible dose, and obviously insulin remains a backbone of therapy. So what are the reversible factors? Modifiable, very important: hepatitis C, cytomegalovirus, pre-transplant obesity, dyslipidemia and metabolic syndrome are important reversible factors which we need to focus prior to transplant. Again, most importantly, because of the medications like tacrolimus, the betas, unlike a type 2 diabetes, here the major pathophysiological problem is the beta cell, the function is worsened early on because of higher doses of steroid as well as because of use of tacrolimus or calcineurin inhibitors as well. So what we had seen was the incidence was about 25% and most developed within the first 6 months. Again, a risk code also we had developed with regards to our population, which includes BMI, age more than 40 years, and very importantly the glucose level, fasting glucose level on day 1 as well as day 5 after transplant. So what are the immunosuppressants? Again, what we need to emphasize, choice of immunosuppressants should be according to the best survival of the patient. Tacrolimus should not be withdrawn, neither should steroid be withdrawn because there is no data. Again, the problem with mechanism of action with regards to tacrolimus and diabetes is basically they cause direct pancreatic beta cell toxicity, reducing insulin gene expression and insulin release. So that is a major issue with the calcineurin inhibitor. So most would require a secretagogue or a DP4 or insulin. Steroids also can impair beta cell function but also increase insulin resistance, and sirolimus increase insulin resistance. So what should be the target? Generally it is 7, but 7.5 can be acceptable. That also should depend on the post-transplant GFR as well. Even up to 8 or 8.5 can be acceptable. Most post-transplant diabetes or NODAT would have a GFR in the category of stage 3. Again, insulin should be used inpatient, also for symptomatic patients. Once the GFR is more than 30 and the patient is clinically stable, metformin can be used. Other than that, we can use DP4, SU, meglitinides, pioglitazone and GLP-1, especially hypoglycemia with SU and meglitinides. SGLT2 only if the GFR is more than 30, and especially we need to be careful about the urinary infections. In the ICU after transplant, most would require insulin infusion, trying to maintain a glucose between 110 to 140, at least less than 180. In the non-ICU, pre-meal should be less than 140, post-meal less than 180. When the patient takes orally, we can shift to basal bolus. People would require insulin, especially immediate post-transplant, first week post-transplant when they are basal bolus therapy. Also, if they have acute rejection, acute steroid doses are required, or patients are on parenteral nutrition. Again, what is very important with regards to insulin is that patients who require higher doses and acute illness or sepsis would require insulin. Perioperatively as well, once stable, we can shift to subcut basal bolus. Very important because of the use of steroid, you can see out here that the peak level occurs after lunch. So the highest insulin dose requirement is actually at lunch compared to most of the hospitalized patients where the highest dose is actually breakfast because of the rise of counter-regulatory hormone levels. The highest is at lunch, then at dinner, and lowest at morning as well. Any regime, basal bolus or split mix or premix regime can be used. There is some good data with early good control, especially with basal insulin, preventing NODAT in about 70% of patients. Metformin can obviously be used as first choice. They have good cardioprotection and anti-neoplastic property, but we need to be careful about GFR more than 30. And sick day rules: if they have infection, dehydration, hypovolemia, we need to stop metformin. We had done the first study, this one is 2013, where we showed linagliptin was effective as a monotherapy in about 70% of patients. No dose adjustment was required initially in rapidly changing GFR post-transplant. So that is a benefit, and there was no drug interaction as well along with GFR. So this is what we had seen, one of the first prospective studies which we had done, and that was first done with linagliptin because they do not need adjustment in GFR. They have few side effects, DPP4 inhibitor, no effect on GFR, and the A1C reduction is about 1%. We also did a 1-year long-term outcome study where we first used linagliptin as a first OHA, metformin as second line if the GFR was more than 30. Then we brought in the secretagogue, especially ripaglinide, and then the basal insulin. As you can see, the insulin obviously had highest efficacy and followed by triple or double OHA, and then the linagliptin 0.8%. But again, the weight gain was higher, about 2 kgs with an insulin-based regime. Hypoglycemia was also higher with regards to the insulin-based regime. But thankfully, though we didn't use SGLT2 inhibitors, there was no impact on GFR with regards to any of the anti-diabetic agents or use of insulin. 70% or nearly 90% had their A1C below 7.5. Most 20% required insulin. Mind you, this is within 1 year. Unlike type 2 diabetes, 1 year 20% required insulin. About 40% were on dual therapy, 15% were on triple agents, and only 25% on linagliptin monotherapy. Again, GLP-1 has a similar effect on glucose versus type 2 diabetes, but there are few small studies. Again, there is a reduction in insulin dose, especially in obese type 2 diabetes patients as well as those who develop NODAT as well. There was mention that prior to transplant, one needs weight reduction, so GLP-1 remains also a good option. With regards to glitazones, actually pioglitazone can be used. No dose adjustment is required, but we need to be careful about fluid retention, heart failure, bone fractures, especially with use of steroids. So these are things which we need to be careful, but pioglitazone, if monitored, can be used as well in this population. Again, coming to SGLT2 inhibitors, there is good data. One, there is a RCT with empagliflozin. Already there is also a study with canagliflozin. But mind you, in CKD patients, the A1C reduction is only 0.2% because already the GFR is significantly reduced even after transplant as well. The weight loss is about 1.6 kgs. UTI and GUI are important. There can be euglycemic ketosis as well as necrotizing fasciitis has been reported in this population. And UTI actually can lead to worsening of the GFR, at least temporarily. And we do not have the cardiorenal protective data as of now. So management with regards to newer agents, obviously there are cardiovascular benefit with GLP-1 and SGLT2, both cardiovascular as well as renal benefit because of decrease in inflammation as well as natriuresis. But we need to be careful with UTI, GTI as well as DKA with SGLT2, and with regards to GLP-1 with regards to GI tolerance as well. Now the key messages. So NODAT, or what is now called post-transplant diabetes, is common. So the number of transplant have increased significantly. So if you go by the data, even our data, we have about 30%, 25 to 30% of patients, those who didn't have diabetes would have NODAT. So we have to treat, and we have to be all aware of the fact. One important issue is that it's much more aggressive because of the added load of prednisolone as well as immunosuppressant. They develop the complications earlier, especially infection and cardiovascular disease, that leads to worse patient as well as graft survival. But we shouldn't be compromising on the immunosuppressant because that prolongs graft survival. We need to stratify the risk prior to transplant. And also individualized therapy according to comorbidity. The A1C goal is about 7 to 7.5. The AHA, however, there is not enough guidelines with regards to the hierarchy of use. Generally, metformin can be used, but We need to be mindful of GFR and it should be discontinued in acute setting. DPP-4 is a good choice because the secretory defect is important. We can use a short-acting glinides because that is associated with lower risk of hypoglycemia. Insulin is a backbone of therapy, especially in inpatient and acute setting and infection, and also for prevention. GLP-1, there is emerging data, but there is increased GI tolerance. SGLT2, the cardiorenal benefit is still not demonstrated, and we need to be careful about infection, and the A1C lowering may not be that much. So we need to generate more data, but we need to select our patients appropriately. We need to screen them in a timely fashion, initiate therapy so that we can prevent the complications as well. Thank you very much. Thank you for a patient hearing.